So we've decided that you're the right candidate to have a knee replacement. What happens now? What happens when we made that decision and you leave this office? Well, a couple things. One, we're going to have to get labs to check and make sure you're going to fly right through the surgery. So we're going to get some lab work. We're going to do an EKG tracing of your heart. If there's any issues there, we're going to do a stress test on your heart to get cardiac clearance and make sure your body can withstand the stress of surgery. Surgery is a little bit of a stressor to the heart. We want to make sure your body has the reserves to fly right through it. Then you're going to come back and visit my PA. He's going to go through all that lab work with you. He's going to go through all the things to make sure the I's are dotted, the T's are crossed, and you're ready for the surgery. Then there's also a class at the hospital. Here in St. George, we've got a 2-hour class that we've worked hard with the nurses to develop. And they go through everything with you at the hospital. What are your options when you come in terms of anesthesia? What tubes are you going to be hooked up to when you come out of surgery? How fast do we unhook those? They're going to show you where you do your therapy and make it so hopefully you have no anxiety when you show up the day of surgery. You know exactly what's going to happen. The day of surgery, obviously nothing to eat or drink after midnight. Okay, the medicines that you take that morning are only your blood pressure medicine, your cardiac medicine, and seizure medicines. Your diabetic medicine, we just want you to take half of, and then we'll monitor that once you get to the hospital as you're waiting for your surgery time to begin. Do not take any anti-inflammatories, okay, for a week prior to the surgery, as that thins your blood out. We'll talk to you further if you're on blood thinners about whether we're just going to stop those or whether we need to do a bridge with a short-acting blood thinner. Okay, what are our anesthetic options? You have a couple when you come in, and it's your choice as to what you want to do. We will accommodate that. The anesthesiologist will talk to you about a spinal anesthetic versus a general anesthetic. Some studies have shown that in anybody with heart and lung problems, anyone a little bit older, the spinal anesthetic is safer than the general. For the postoperative pain control, what can we do? There's a femoral nerve block where they can put a little IV catheter right below your groin and just numb up that femoral nerve. That can work very well, but we have seen some muscle weakness with that, which can hamper your immediate postoperative recovery. What I prefer to do is inject a cocktail of a different group of medicines that we've come up with all around the muscles and skin of the knee. We have found great pain control with that. It doesn't affect the muscles, so you can get up and walk. Last year we did a survey of the nurses, and this method that I've brought to this town was found to be the most effective and that preferred by the nurses and patient for immediate postoperative pain control. What happens when you come out of surgery? Well, you're in the recovery room for about 45 minutes, then you'll make it up to the floor, and that's where your family will see you. As soon as your legs wake up from that spinal anesthetic, the physical therapist will visit with you. Their goal is to get you out of bed and walk either just around the room or down the hall, depending on how you feel and how strong you're feeling. Pain management afterwards, I try and give you a lot of non-narcotic painkillers so that you won't have to use as much of the narcotics. We hopefully eliminate then some of the constipation, some of the nausea, some of the feelings that the narcotics can give you. But the nurses are constantly checking on you. Your pain control is our top priority for that first day. How long are you in the hospital? Anywhere from 1 to 3 days. Okay, so most people go home day number 2. Sometimes these are even done at the surgical center, and people leave an hour or so after surgery. What are the different options when you leave home? Well, it depends on how good you're doing, okay, and what situation you have at home. I think the people that do best are the ones that go straight home and then they go to outpatient physical therapy. They have their spouse or family member drive them down to physical therapy 3 times a week, where they have all the machines they can hook you up to, the electrodes, the exercise bikes, and you can work hard that way. If you don't feel up to that and it's not safe to do that, we can have the visiting nurses come to your house, the home health agencies, which do a wonderful job. Their therapists will move you around and do as much as they can in the comfort of your own home. For those that live by themselves or are really slow moving, there are skilled nursing facilities that one can go to. Those are a little dependent now on your insurance companies allowing that. I cannot force them to allow you to go there, but if someone needs that help, you can go stay there for anywhere for 2 to 3 days to 2 weeks. to again work on strengthening. Again, I think the therapy is best at an outpatient center, but we have all three of those options available for whatever you need. After surgery, we need to keep you on some blood thinners for a while. The risk of blood clots is there for several weeks. We used to have everybody on Coumadin or Lovenox, but we found what we consider to be an unacceptable level of bleeds and wound draining complications from that. Recent study out of Europe has shown that if people are up and moving quickly, that aspirin has been just as effective. So that is what we're doing now, is starting people on a full dose of 325 milligrams of aspirin the day of surgery, and then getting you up and moving you quickly. If you have a history of blood clots, if you are at high risk, whether that be you're obese, you're a smoker, you're on birth control pills, history of cancer, a history of blood clots in you or your family, then we have the option of possibly going a little bit stronger, going back to the Coumadin or the Lovenox or the Xarelto. We can talk about their advantages and disadvantages.